Good evening and namaskar and a very warm welcome for today's webinar on Oncology Reboot 2024. With immense pleasure, I would like to invite Dr. Jagdeep Singh, who is Consultant Medical Oncologist at Cancer Centers of America, Amritsar, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Thank you, Mrs. Ekta. So, good evening, everyone. Yesterday, we had a discussion regarding breast cancer and what are all the updates from the ASCO and some of the discussions regarding the metastatic breast cancer. So today, our topic of discussion will be on lung. So there are some of the updates from the ASCO regarding some of the TKIs which has been in the adjuvant settings, and some inputs from my medical oncologist league regarding liquid biopsy, and we'll be covering shortly the latest updates in that. So now I'll be requesting Dr. Kanupriya. She is a medical oncologist at Oswal, Mondai Oswal Cancer Hospital, and she will be delivering a lecture on liquid biopsy in NSCLC lung. So the lung is such a dynamic disease. So we have a lot of mutations, and sometimes we are not able to retrieve the tissue blocks, or we are not able to get a new biopsy. So we have to really rely on liquid biopsy for those purposes. So she will be giving a lecture and she will be highlighting what things we are doing and how to interpret that report from the liquid biopsy. Over to you, Dr. Kanu.
Thank you, sir. Good evening, everyone. And thank you for giving me an opportunity to talk on such an integral topic for lung cancer. So can someone share my slides, please?
So technical team, so just share the slides for Dr. Kanu.
Sharing.
Slide, please. Next slide, please. So lung cancer, what we all started with, just two histologies, small cell lung cancer and non-small cell lung cancer. We all know now we have different and various pathologies and biologies which actually drive various kinds of lung cancer. So in non-small cell lung cancer, there are tumors which are molecularly driven. They have particular driver mutations, which we fortunately can target with wonderful results. And those who lack these mutations, we have the expression of PD-L1, which guide us with the treatment. So the present view of the lung cancer is so comprehensive, so vast, but it can help us guide every lung cancer in a different manner. So every patient is unique. We need to find what patient comes to in our OPD, what is the pathology, what biology is in that particular patient. Next slide, please. So it is said that 50% of the non-small cell lung cancer, either you will find a target which has a drug right now, or you will be able to find a clinical trial for your patient where you can put that patient for one or the other upcoming targets. So the most common we all know are the EGFR mutations followed by ALK and ROS. KRAS are the ones which recently we have found a target where which particular drug, sotorasib, which we can use. And there are various other targets also like BRAF and HER2, NTRK, which can be targeted. Next slide. So these are the success stories. I do not emphasize, I don't need to emphasize more on them. The CROWN trial, where we have the updated more than 5-year result now. With the use of lorlatinib, we can see that even at 5 years, the median PFS is actually not achieved as compared to using crizotinib. These curves speak for themselves. And obviously the FLORA trial, where osimertinib compared to other older TKIs, we have an overall survival benefit. So it's very important for us and very fortunate for us also. If we have a particular driver mutation, if we are able to find it, we can target it and give the particular drug for that driver. Next slide. So this is a study I would like to mention here, where Dr. Charu actually showed the association between the overall survival of NSCLC patients and what its association was with the molecular genotyping. Next slide. This was actually a retrospective study. Next slide. And what she actually did in these patients was she retrospectively compared the survival of the patients with their genotypic data that was present. What patients, she compared those patients who had the genotypic results before starting of the first line therapy and those who did not. Next slide. This is the overall survival curve. We see that the patients who had a comprehensive genomic profiling available before the starting of first line treatment, they had an overall survival of nearly 2 years, as compared to those which was who did not. The overall survival was just 6 months. So that is the amount of difference a well done comprehensive genomic profile can have in metastatic advanced non-small cell lung cancer. Next slide, please. Next slide. So these are the conclusion that that the paper actually came to, that performance, if you do a comprehensive tissue as well as a plasma NGS testing before doing starting the first line therapy, it will improve the overall survival of your patient. And these results support that doing a concurrent approach will help you in a longer way with the patient. Next slide. So now my next slide will actually take you to a quote which we have been listening day in and day out in any conference, in any CME of lung cancer that we attend, that in lung cancer, tissue is actually the issue. Next slide, please. So yeah, tissue continues to be an issue in 2024 too. Next slide. So this is what we actually want from our interventional radiologist or our pulmonary specialist, that we would get a tissue which is so vast that we can do the diagnostic markers, then we can do the non-DNA markers like PDL1, and we can do the molecular markers, when in reality we actually get a very small tissue. Either the tumor was very peripherally placed, a very small tumor from the lung where biopsy was not feasible, or it was just a bone biopsy that was done. So till the patient reaches to you, there's just one block where either you can you're just barely able to do the diagnostic IHC testing. Next slide. So you get a limited amount of tissue in many of these patients. The site of the disease is such that a blind biopsy or CT guided biopsy was done. Most part of it is either necrosis and very little tissue is available. Or sometimes what happens is patient comes to us in second or third line setting. So the archival tissue was there. Maybe it's not available right now, was done in some center and they don't have your specimen. So the age of specimen is very old. Or sometimes, like I recently had a patient who had come to me with just a bone biopsy. So bone biopsy, they take time to decalcify. The amount of DNA that you procure is so less, you are not able to apply all the required molecular markers. So these are the issues with the tissue that continue to be there in cases of lung cancer. Next slide. So even if you get a good amount of tissue to begin with, and maybe it's looking like we've not written the correct history, so the pathologist will not know where to begin. There's a biopsy sample, so he will start putting the markers. He'll put TTF1, P40, and the other markers to rule out other diagnoses. So till you reach a diagnosis of lung cancer, there is barely any tissue left with you to put molecular markers and do PDL1. So the patient will come to you that tissue में कुछ बचा नहीं है, अब ये test तो लग नहीं सकता. So this is a problem that we face almost daily with whenever we see our patients of lung cancer. Next, please. So that is where liquid biopsy comes and actually saves us. Liquid biopsy is actually a fingerprint of the tumor. Tumors keep on shedding their DNA into the bloodstream, which we have now made use of. So you can measure cell-free DNA or circulating tumor cells, cell-free RNA, or the exosomes or the microvesicles. They actually contain a lot of information and they represent what the tumor is genomically made of, the platelets or the WBCs and RBCs, and this is what actually liquid biopsy is. Next. So circulating tumor cells, it said that nearly 75% of advanced any cancer cases will have a circulating tumor DNA, and the amount of DNA in the blood depends on the tumor burden, the tumor type, and at what point of therapy are you in, whether this is first line, second line, or third line. So ctDNA's quantity depends on that. Next. Next. So I've made a table and we all are very well versed with this. I'll begin with tissue biopsy. Tissue biopsy is the gold standard. It will tell you what type of cancer it is, whether it's small cell or non-small cell. And then you'll be able to put not only the DNA markers or the molecular markers that we are looking for, but also the non-DNA markers like PDL1. However, it is associated with longer TAT. So it will take 7 days for your histopath to come, then 7 more days for some markers, and then further molecular markers. So approximately 21 to 28 days it takes till you can give answer to your patient. Most of the time, like I said, there's a very limited tissue available. So you are in a dilemma on what to send and what not to send. Obviously, it's an invasive procedure. And at progressive disease, a rebiopsy is not always possible. Patient will just not agree to do a biopsy. They'll be like, "Pehle bhi hua tha biopsy, usi se ab hame karna kyun hai?" And it'll be troublesome and painful also for the patient. And obviously, we will be missing tumor heterogeneity in many of the cases. If I compare to liquid biopsy, on the other hand, as I will be discussing later in my slides, liquid biopsies actually do have a very high concordance with the actual tissue itself. There's a rapid TAT. So for some of the liquid biopsies, you might get an answer for your patient within 7 days for some mutations. It's obviously minimally invasive, can be repeated at every progression. So you can see how the tumor is actually evolving. You can capture tumor heterogeneity and the clonal evolution. However, you'll not be able to put the non-DNA markers. It's obviously very costly, and there is a chance of missing out on some mutations and some molecular markers because of false negativity. Next slide. Sorry. So like I said, it has a high concordance. This was the complete study which was done, which compared the plasma versus the tissue molecular markers retrospectively. The plasma test was Garden 360, and they saw that Garden 360 had a positive predictive value for the most common mutations that we see, and the PPV ranges from 98 to 100% actually. Next, please. Then this was the Nile study done again, which actually highlighted the importance of Garden 360. So in patients of NSCLC, when just a tissue biopsy was done, it was able to identify 21% of the mutations which were present, targetable mutations. As compared to when they were using Garden 360, they were able to identify 27% of the molecularly targetable mutations. And this difference was actually statistically significant. Next. So now the question comes on when a case of NSCLC comes to you, what do you send then? Do you send the liquid biopsy first or do you send a tissue biopsy first? Well, there's no correct answer for that. I will tell you the benefit and the disadvantages of doing either. There are two approaches. You can go for a sequential approach. So first, if you have an ample tissue available, you send for a tumor tissue genotyping, you wait for the result. If there is a negative result, then you can probably go for a liquid biopsy. The second is the complementary approach. That is, you send both of them together, just the tissue biopsy and the plasma also for liquid biopsy, and then you wait for the result. And the third method that you can actually do is a plasma first approach. Maybe the patient comes to you and the tumor site is such that a biopsy is not feasible only. So you can, or the patient is very sick, you need an answer. Your clinical judgment say that there is a high possibility the patient might have an EGFR or an ALK mutation. So you can follow a plasma first approach also. And if there's negativity, then maybe try for a biopsy, however hard it is. Next. So I said that the TAT actually significantly differs. The Nile study again showed that there's a difference of almost significant 10-day difference, which actually impacts the overall survival also. The tissue takes time to give you the results, whereas the blood takes almost 14 days maximum, and you will get a result about your patient. You will be able to answer the patient in the OPD on how the approach to treat will be. Next. This is again an Indian study which showed the same. The EGFR TAT with liquid biopsy is much lesser as compared to the tissue biopsy. Next. So this will probably help you understand better the paradigm one, where you send and wait for the tissue result. It will take 14 days, like I said. If the tissue result is negative, then you send the liquid biopsy. So a total of 21 days if you are following either sequential approach. But if you send both of them concurrently, then you will have an answer. If the liquid biopsy comes positive in 7 to 10 days, or maximum by 14 days, you will have an answer about the tumor biology for the patient, and you can map out the treatment protocol for him or her. Next. Which is why, seeing all these advantages, NCCN now has incorporated liquid biopsy in the testing strategy. They say that you can test the peripheral blood concurrently with the tissue to achieve the comprehensive genotyping for a patient of non-small cell lung cancer. Next. There are times when you actually depend on liquid biopsy for the result. I recently had a patient who, like I said, just had a bone disease. There was a very small lung nodule where I could not biopsy. I tried to biopsy the bone lesion along with the soft tissue twice, could only get necrotic tissue, had sent liquid biopsy along with that, which then showed an exon 19 deletion. So I had an answer in 7 days. So these are times like that, or if patient has progressed in the brain or has a leptomeningeal disease, so you don't know how to biopsy that. Liquid biopsy in these cases can be a lifesaver. Next. It's just not diagnostic. The slide shows that liquid biopsy can be prognostic also for patients. This is the data from Flora itself. So on the left, the figure A that we see that patients who pre-treatment had a positive ctDNA, their median overall survival with using osimertinib was 15 months as compared to those who did not have a positive ctDNA. I mean, they had a negative ctDNA. There, the median PFS was 24 months. It actually denotes probably the burden of the disease only. So that ways also prognosticating your patients, it can help. Next. Next. So having said that, having shown all the positive things about liquid biopsy, we should remember, next slide, we should remember that we are sending the test in a lab or sending a test which has been studied well, complete analysis has been done, and there is a clinical validity where the importance of Garden 360 comes in. Next. Yeah. So I've discussed the role of Garden 360 in advanced settings. However, liquid biopsy, the role is now coming to early NSCLCs also. Trials like NADIM and other chemoimmunotherapy trials actually have used liquid biopsy as a prognostic marker. Also in NADIM, it was seen that patients who had a higher ctDNA level pre-treatment or who had a positive ctDNA after chemoimmunotherapy, they had a lesser PFS and OS as compared to patients who had a negative ctDNA after chemoimmunotherapy. Even in adjuvant settings, this has been tried, and that is probably the future of what lung cancer is going to be. And in studies and tests like CancerSeek and all, liquid biopsy is now being used for the screening of patients who, for people who are at high risk of developing lung cancers also. So that's where we are looking for lung biopsy in few years. Thank you.
Thank you, Dr. Kanu. So despite you are not well and still you took that efforts to deliver this lecture. So I just want to ask practically, so do you send both the tissue and this plasma sample in your practice? Because I don't send, and I'm basically, I feel that patient is having so much of financial constraint.
Yes.
So it's sometimes I find very hard to send even the tissue, a single sample also.
Yes, and I am not able to send both of them together because it becomes very difficult to explain to the patient also on why I need to send both of them together. And then financial is always an issue. So till now, I've not been able to send even the patient that I was telling who had a bone-only disease. It's only when the first biopsy came out to be negative, then I sent, at least I should have something. Concurrently, I'm not able to send.
So do you like any rationale for using Jeftinib till the report is available in a patient who's a female non-smoker adenocarcinoma? Do you still practice that?
I do. I
Till
do,
the time
yes.
you don't get any report.
Yes, sir. If clinically the patient is not stable, I'd rather use because there is going to be a 30% chance that she might have that. So I do use that in patients who are clinically not stable. Yes, sir.
Thank you so much. I can see Dr. Kunal Jain. He's there, my senior and my, you can say, path, who can guide me everything on these things. So your input, sir?
Good evening, Dr. Jagdeep. Thank you for organizing this meeting and inviting us. So interesting, very, thank you, Dr. Kanupriya, for this talk. Just curious to know, like for your patient who had bone disease, I know such patients will come once in a while. So without histological diagnosis, the liquid biopsy did show exon 19 deletion, but so what will you label the patient as?
No. So there was an
What
FNA done.
malignancy?
FNA showed adenocarcinoma, but uske baad jo biopsy I had done, that was necrotic. So I had an
Correct.
FNA for the
Correct. So I think that that message is what we need to have a tissue anyway, some form of tissue diagnosis in any form. FNA can give, and then you don't have further tissue, then yes, the liquid biopsy. And I also practice mostly in the way Dr. Jagdeep was mentioning, doing tissue first, emphasis on tissue, and wherever tissue is failing, then liquid. And yes, liquid more for patients who are progressing while on treatment, then using liquid more often than tissue at that point of time.
So, sir, still I feel that whatever the concordance rate for, because most of the studies are available for the EGFR or ALK based, so they are more than 90%. Most of the studies shows also this. But still, whatever I felt, I have recently encountered one patient from Rajiv Gandhi. The liquid biopsy was negative, and the patient then came a positive with the EGFR. So it took me hard to convince that it is still positive. So don't go with the negative reports. First thing. So sometimes we ourselves put the patient in dilemma to which test to go and which test not to go. And sometimes patient does not want to start with the same treatment, which we also sometimes advise at the same time. This is what I think. Thank you, Dr. Kanufi. Thank you so much. So today we have a pulmonologist with us also, Dr. Mandeep. He's my contemporary at the time of family medicine. He's DM in pulmonary medicine. So he will be taking a next lecture on the expanding role of EBUS in CLM. Over to you, Dr. Mandeep. He is presently practicing in Amadhi Medicity, and he's a renowned pulmonologist in Amritsar.
Thanks, sir, for warm welcome. Is my screen visible?
Not, your skin is not visible.
Screen.
Now it is visible. Can you make in presentation mode?
Yeah.
Yes.
Now it's okay.
It's okay.
So good evening, everybody. Today I'll be going to discuss the role of EBUS in diagnosis and staging of lung cancer. So EBUS as a modality, it is a diagnostic modality in which an ultrasonic probe is introduced into the tracheobronchial lumen to provide the sonographic images of the peribronchial tissue. So there are two types of EBUS. One is a convex probe EBUS, which is used to view the lymph nodes in the central airways, and then the other is a radial probe, which is used to take samples from the nodules in the periphery of the lung. So these are the two persons who discovered one radial probe EBUS was discovered by Henrik Becker, and convex probe it was discovered by Kazuro Yasufuku. So what are the various indications? The main indications in India are granulomatous lymphadenopathy, TB, and sarcoid. The topic which we will be discussing today are diagnosis and staging of lung cancer, diagnosis of lymphoma, evaluation of mediastinal lymphadenopathy in patients. In cancer patients, it can be used in transbronchial needle injections of chemotherapeutic agents. And also we can see in special situations like the station 5 and 6, there may be sampling of the mediastinal lesions also. So first, coming to the characters of the lymph node, the ultrasonic view in the EBUS. So first, dependent on the size, whether the size is less than 1 centimeter or more than 1 centimeter, shape of the lymph node, whether it is oval or round in shape, margins, whether they are distinct or indistinct, then echogenicity, whether it's a homogeneous lymph node or a heterogeneous lymph node, then whether the central hilar structures are present in the lymph node or they are absent. Then the coagulation necrosis sign is also an important sign. That is the area of hypoechic area within the lymph node without blood supply. So these are the ultrasonic views. First one, it is a size small is less than 10 mm. Second one is the more than 10 mm lymph node. Third one is the oval lymph node, which you are seeing. And in the fourth section, we are seeing a round lymph node. So other characters are, this is the lymph node with indistinct margins. This is a with a distinct margin. Then the homogeneous lymph node. Here, there is uniform homogeneity in the lymph node. Here, we are finding different densities in the lymph node. Some are less dense as compared to the other ones. In this lymph node, the central hilar structure is well described. And in the last slide, there are coagulation necrosis is there. So how these characters help us to distinguish between the benign and malignant? The round, they are more in favor of malignant lymph nodes as compared to the benign, which are usually oval in shape. The malignant lymph nodes usually have a distinct margin as compared to the indistinct margin, which may be seen in tubercular and other inflammatory disorders. Again, in malignancy, the heterogeneity of the lymph node is seen, which is usually a homogeneous echogenicity in normal lymph node. Then the coagulation necrosis sign, it may be seen in malignant lymph node, and a intact hilar sign, it may be seen in a non-malignant lymph node. So these are the signs where how much percentage of malignancy, how much hazard ratio of malignancy is there. The more important are the margins. They are well defined in case of malignancy, and the coagulation necrosis sign, which if present points towards malignancy. So this is a Canadian lymph node score for predicting malignancy in lymph node. Margins, distinct well-defined margins, they are pointed towards malignancy, absence of central hilar structures, central necrosis, and a small axis diameter of more than 10 mm. If all 4 points are present, there is almost 50% chance for predicting malignancy. So as the probability number of scoring system 3 or 4, they are more predictive of towards malignancy. However, just observing the lymph node, there may be pitfalls, like especially in the Indian settings, tuberculosis may mimic malignancy. Coagulation necrosis sign may also be seen in tuberculosis. So they are not definitive indicatives. So how to perform the procedure for malignancy? We have to sample the highest station lymph node first. That is the N2 followed by N3 followed by N2 and N1. And each station should be considered for possible needle aspiration, regardless of PET avidity. Hirth and Claes identified previously unsuspected malignancy in 9 of 97 patients by sampling lymph nodes less than 1 centimeter in short axis on CT and without FDG uptake in patients on non-small cell lung cancer. So then there is one controversy whether to use ROSE or not. ROSE doesn't affect the diagnostic yield in EBUS TBNA, but it may reduce the number of needed aspirations, because the first time the pathologists say that it is an adequate sample, we may stop, as well as also it reduces the need for other procedures like transbronchial lung biopsies if the sample is adequate on TBNA. So then NGS can also be done on the TBNA samples, as was done in this study, and it showed a positive rate of 86.1%. That is, the samples were adequate for NGS study in 86% of the cases of core biopsies taken by TBNA. So this is a systemic review and meta-analysis, which also showed almost similar sensitivity, 86.5% for NGS. It was done in, we are able to do in 86% of the cases in which we had taken the core biopsy. So for NGS, we may need to take almost 5 to 6 passes. In normal, we are taking 3 passes per lymph node, but for NGS, the number of passes required may be more. So again, there is no difference in the outcome with the use of 19, 21, and 22 gauge needle. Although the 29 and 19 gauge needles, it may give a larger amount of material, but they tend to be more hemorrhagic. So what are the complications of EBUS? They are pneumothorax, massive bleeding, cough, infection, airway edema, respiratory arrest, left mainstem bronchus laceration. Usually they are rare side effects. Most common complication, they say, is the injury to the EBUS scope rather than the patient. So despite the addition of EBUS TBNA, nodal staging in non-small cell, these are the pitfalls of EBUS. It failed in 21 of 264 patients, that is 8% of the patient. These were mostly patients which were difficult to reach stations like 10L and 11L, or the PET was negative in these stations. They did not take sample from these lymph nodes. And there were no insignificant EBUS findings in some that they didn't do the biopsy there, TBNA there. So this is the pitfall. Whether the subcranial lymph node, it was on EBUS, it was normal, on PET, it was normal, but on thoracotomy, it showed that subcranial lymph node was positive. So these are the various modalities which were used for diagnosis and staging of lung cancer. One is the EBUS for central lesions. For pleural-based lesions, we may use the true cut biopsy, and for peripheral lesions, we may use the radial probe. So these are the advancements. Starting with the CT, more invasive ones are the VATS and thoracotomy. As the degree of invasiveness increases, so the surety of diagnosis also increases. So first is the CT scan. It is bound to miss. Almost 40% of the nodes deemed to be malignant by CT are benign, and 20% of the nodes deemed to be benign by CT are malignant in a study published in 2007. Again, PET has a good sensitivity of 74% and a specificity of 85%, and combination of node size and metabolic characteristics improved accuracy of staging by better anatomical localization of the FDG hotspots. For most patients, integrated PET-CT doesn't eliminate the need for invasive PET testing. So in patients with small peripheral tumors without enlarged nodes, mediastinal nodes, less than 6% of the mediastinal nodal metastases are there. So most clinicians use these criteria to rule out mediastinal involvement and can proceed directly with thoracotomy in these patients. Then in the conventional TBNA, it has a low yield, almost 30% yield. So then the better yield is that of mediastinoscopy. Before the advent of EBUS scope, sampling of the mediastinum was mostly done by mediastinoscopy. Invasive procedure performed under GA. So there was a need for EBUS scope. While mediastinoscopy had the better yield when sampling mediastinal lesions, it was at the cost of it being an invasive procedure being done under GA. The lesser invasive procedure, conventional TBNA, had a low yield. There was a need to develop an instrument which was less invasive as TBNA, conventional TBNA, and which had a good yield as mediastinoscopy, facilitating real-time sampling. So EBUS is the preferred mode for this. There is a one scope for all mediastinal lymph node stations, highest diagnostic yield, well tolerated, very safe, and cost effective also, as compared to mediastinoscopy. So these mediastinal lymph node stations you all very well know. So all the stations documented in red can be approached by EBUS TBNA, 1R, 2R, 4R, 10 R and L, 7 subcranial lymph node, and 11R and 11L. The stations which are usually not approachable are the 5 and 6 and the 8 and 9 lymph node stations. While the EGUS endoscopic ultrasound, it usually approaches the left side of the mediastinum, 1, 2L, 4L, 7, 8, and 9. So both of these, EGUS and EBUS, they are complementary. EBUS can sample 2 or 4 or 10, 11, and 12. EGUS 8 and 9, both can sample 2L, 4, 5, 6, and 7. However, 5 and 6 stations usually require transvascular access, which is rarely done if no other option is available. So both the procedures are complementary and can has been described as medical mediastinoscopy and can achieve yield in up to 90% of the cases. So in this review, almost 91% sensitivity of combined procedure of EBUS and EGUS in lung cancer staging was there. So some have used the EBUS as a EGUS scope also, and they have obtained yield of 90 to 91% for mediastinal staging. So advantages of EBUS over mediastinoscopy are ability to assess higher nodes, comparable diagnostic yield, can be performed without GA, better safety profile, easier access to EBUS, lesser cost, and repeat procedures are easier to perform. So the safety of EBUS is much better as compared to mediastinoscopy, although serious adverse effects are less for both the procedures. EBUS, there is a risk of lower vocal cord palsy and has lower cost as compared to mediastinoscopy. So the comparison of EBUS versus mediastinoscopy, the major adverse effect during mediastinoscopy occurred in 2.4% of the patients: tracheal injury requiring muscle flap coverage, EJV requiring vessel ligation, left recurrent laryngeal nerve palsy, and left vocal cord paralysis that lasted for 4 months. While major adverse effects seen during EBUS TBNA occurred in 1.2% of patients: left main bronchus laceration requiring surgical repair, and massive hemoptysis controlled with endoscopic intervention. So these days they are saying that if the nodes are negative by EBUS, we may proceed directly to thoracotomy rather than going for mediastinoscopy staging. So these are the yield of various diagnostic modalities. Most sensitive is the VATS, but it usually approaches one side of the mediastinum only. For bilateral, you need to do a bilateral VATS. So this is a diagnostic yield for EBUS TBNA for mediastinal staging. Almost 90% yield is there. So these are the current staging protocols being followed. Two are similar. European Society of Thoracic Surgeon. Currently, we do a CT and PET. If mediastinal lymph nodes are negative in both and the tumor is a peripheral one less than 3 centimeter, we may directly proceed with the surgery. However, if the tumor is by CT scan N1 or central tumor is there or tumor is more than 3 centimeter, we require tissue confirmation initially by EBUS and EUS or mediastinoscopy. If mediastinal lymph nodes are negative, we may proceed with surgery. However, if the mediastinal lymph nodes are positive by CT and PET, we definitely require tissue confirmation. If the nodes are positive by EBUS or EUS, then it is a multimodality treatment. And if they are negative by EBUS, then we need to do a video-assisted anterior mediastinoscopy. If they are negative, we can proceed to surgery. So similar, they have been published recently guidelines. So then coming to the peripheral nodules, we are using a radial probe EBUS. CT biopsy has a better diagnostic yield as compared to radial EBUS. Difference was larger when the lesion was smaller or proximal to the pleura, and significantly higher complication rate like pneumothorax is seen with CT guided biopsy. And drawbacks of CT guided biopsy, it is difficult to assess lesion deep in the lung parenchyma, difficult to biopsy lesions close to major vessel, difficult to biopsy GGOs, lesions within the background of emphysema. There is a high risk of pneumothorax with CT guided procedures, and inability to perform simultaneous lavage bronchial washing, because in India, nodules, they can also be due to TB and other causes also. And we like to have fluid also. So these are the various studies in the radial probe. Radial probe gives a better yield if there is a concentric lesion as compared to if there is a centric lesion. So diagnostic yield with concentric view is up to 84%. With the eccentric view, it falls to 48%. If we are using a guide sheet, the yield is significantly better as compared to if we are using without guide sheet. And thus, as the size of the lesion increases, the diagnostic yield also increases with radial probe. So this is the CT bronchus sign, that is the bronchus is directly leading to the nodule, then the yield is better. So bronchoscopic procedures can be divided into before radial probe intervention and after radial probe intervention. Before radial probe bronchoscopic methods, they used to yield around 30% of the diagnosis. So it was considered that they should not be routinely recommended. But after radial probe was discovered, the yield increased much. Overall diagnostic yield of 70%. For nodules less than 2 centimeters, it is around 60% with a completion rate of 2.8%. So these days, it is recommended as an initial test. So radial EBUS is the bronchoscopic modality of choice for sampling peripheral pulmonary nodules. The diagnostic yield is inferior to CT guided biopsy, but the safety profile is superior. Combination of biopsy, brushing, and guide sheet likely to give the best results. Severe additions to radial EBUS helps to increase the yield, like cryobiopsies, ultra-thin scopes. So presenting two cases also recently seen. First case is of that of 65-year female. She was having right breast carcinoma diagnosed in 2020, had undergone mastectomy plus chemo and radiotherapy, was asymptomatic for 2 years. Now presented with cough and low-grade fever for 2 months. So this was the PET CT showing us a PET active subcarinal lymph node. So this case presented to Dr. Jagdeep, and we did the EBUS in this case, and it came positive for MTB. So patient was initially referred for modified chemotherapy to some other oncologist, but then came to Dr. Jagdeep, and subsequently I did the EBUS here. So then the second case presented with 1 year history of cough breathlessness. So it was a mass lesion in the left upper lobe. Here we did EBUS, PET CT was there. It showed a left upper lobe hypermetabolics and a subcarinal lymph node. So did bronchoscopy plus EBUS. There no endobronchial lesion was seen. TB was negative. Left upper lobe TBLB was taken, which showed a granuloma. Also, EBUS was done, TBNA was done, as there was no endobronchial lesion. It again showed granuloma, but TB was negative. In MTB PCR was negative. So we did a suspecting CA. We were suspecting CA from the beginning. So we did a peripheral CT guided true cut biopsy, which yields squamous cell CA. So again, for confirmation, we did the cell block IHC on the TBNA, EBUS TBNA, and it also came to be negative. So rarely granulomatous inflammation has also been reported in squamous cell CA. Like in this case report, they have recommended a 75-year-old man with pulmonary squamous cell CA, where granulomatous inflammation was observed extensively at the primary site, as in our case, where lymph node was also granulomatous and TBLB was also granulomatous, but the periphery gave us the diagnosis of squamous cell CA. So these are the pitfall the EBUS missed in this case, the diagnosis of squamous cell CA. So to summarize, mediastinal lymph nodes on CT or PET, if negative, lesion is small, less than 3 centimeter, directly proceed to surgery. Tumor more than 3 centimeter, tissue confirmation by EBUS TBNA. If negative, these days they say proceed directly to surgery. If the immediate PET CT is positive, tissue confirmation by EBUS TBNA, lymph node positive, multimodality treatment. If negative, we may do a mediastinoscopy. Negative, then proceed with surgery. Thanks.
Thank you, Dr. Mandeep. It was a very meticulous presentation of how to proceed with the for the lesion for the with the EBUS and this TBNA and the TBLB. So
Thanks.
thank you. It was basically we used to send the patient for these procedures, but honestly, the depth and detail we are unaware of these things. What you tell this about the radial EBS, which still the yield might be less than the CT guided, but if you use a sheath along with that, you might get a good result. And maybe I can avoid a patient with a dreaded complication like of pneumothorax, which a patient if develops gets scared of getting a treatment. So a lot of things you just shed a light on those things, and it really give us information that we can skip this invasive mediastinoscopy, which was there initially, but for that, if we are expertise person who can do this EBUS. And I'm happy to share with my colleagues that Dr. Mandeep, he is very aggressive in these procedures, and sometimes we feel that pulmonologists at some point might want to avoid because of the complication, but he rarely feels like that, and he's always there for helping us to get the adequate diagnosis. And I think I still remember there are some 5-6 patients which we were suspecting initially malignancy based on the imaging and other findings, but it proved that there were granulomatous. And one of my relatives is also there who got treated for the same, and he is doing pretty good. Thank you so much, Dr. Mandi. Thank you so much.
Yeah, thanks. Thanks.
So this was regarding the role of EBUS in CA lung, and there are the different modalities which can be used in doing the staging or even in the diagnosis. So next lecture will be by Dr. Satyankar Gupta. He is a medical oncologist at AOE Jammu. So in the lung, the drugs initially started as in metastatic setting in the second line, then come to first line. And now we have shifted this drugs. There is shift of this paradigm to the adjuvant in patients who have received this CTRT and post then consolidation with TKIs, maybe with either osimertinib in this particular subset of patient or this alectinib, like what we are used to give for durvalumab. So over to you, Dr. Satyankar. So you the lecture will be the adjuvant role of this EGFR mutated lung cancer. So LAURA trial you will be discussing with you.
Thank you. Thanks, Dr. Jagdeep. I'm available. Please share my slides, Abhinyu.
Sharing, sir. One second.
So Dr. Satyankar, your camera, I think you can switch off your camera, then it will be connectivity will be a bit better.
Okay. So am I audible?
Yes.
Okay. So we'll be discussing reinventing adjuvant therapy in the EGFR mutant early stage lung cancer. Next slide, please. Next slide. Yeah. So survival outcomes in early stage lung cancer need to be improved. Moving from stage 1B where it is close to 65 to 75%. In stage 2 it drops down to 50 to 70%, and in stage 3A it drops down even further from 30 to 45%. Next slide, please. So EGFR mutations, the prevalence rates all across the world, they range somewhere around 10% to 50%, whereas in the Asian population, they are around 30% to 50%. The risk of disease recurrence following post-operative chemotherapy or other definitive treatment may be increased in patients with EGFR mutation, because previously mutation testing was not done and only chemotherapy was given. So mutation testing has to be done for early stage non-small cell lung cancer. And there is definitely an unmet need to improve the 5-year overall survival, which is currently ranging approximately 45% to 80% in stage 1B to 3A. Next slide. Now, coming to testing recommendation for early stage lung cancer. For metastatic, we all know, we currently, as discussed in the first talk by Dr. Kanupriya, we all send that NGS panel comprehensive genomic profiling that we do, and the PDL1. But for the resectable ones, currently the recommendations are only for EGFR testing as well as the PDL1. Next slide. So, the most number of patients will be exon 19 deletion, followed by like NTM and 18 mutations, etc. But majority ones are the exon 19 and the exon 21. Next slide. So if you see prevalence of EGFR mutation in resected patients, now these studies show that majority of the patients, almost 73% of the patients, actually undergo only surgical resection. Like in stage 1A, 96% patients are undergoing only surgical resections. So, and few of them end on getting adjuvant systemic therapy also. So there is definitely an unmet need about these EGFR mutated patients. Next slide. So in spite of surgery and adjuvant chemotherapy and RT, 40 to 50% patients will remain disease-free, but unfortunately 50 to 60% will have a recurrence within 5 years. So giving that over half of the patients will recur after curative intent surgery, there is definitely an unmet need for improved neoadjuvant and adjuvant treatment options in order to improve long-term outcomes. Next slide. So this is the NEGM 2004 publication of Anita study, where we gave adjuvant chemotherapy stage 1B to 3 and look at the delta. I mean, in the overall survival as well as the DFS, the delta is there, but it isn't much. And the hazard ratio was somewhere around 0.79 or 0.8. Which wasn't that convincing, but obviously considering the bad subset of these patients, adjuvant chemotherapy is currently being given to all the patients. Next slide. EGFR TKIs in the adjuvant setting were given in the past also. There have been many trials, mostly phase 3 also. Select trial, Radiant trial, Ivan trial, which used various second generation TKIs like erlotinib, gefitinib. Next slide, please. So this is the meta-analysis of 6 randomized trials. So we can see DFS in the EGFR in the adjuvant setting. All these trials, mostly, yes, DFS advantage is there, except this BR19 trial, and hazard ratio is 0.52. Whereas the OS advantage in the EGFR metastatic setting, here we can see the hazard ratio of 0.64. So no OS advantage, please, for this trial. Next slide, please. So to sum up what we have gone through in the previous slide, so there have been trials to date. They have been limited by the design, size, and other factors. There has been no OS survival advantage. Unclear if adjuvant EGFR TKI therapy results in cure or it actually delays the recurrence. And there is no definitive evidence on appropriate sequencing drug, which drug to give, and duration of treatment also. Next slide. So to find an answer to these trials, ADORA trial was designed in the adjuvant setting, and patients with resectable stage 1B to 3A adenocarcinoma histology with or without adjuvant chemotherapy were included, and mostly ECOG performance status 0 to 1, and brain imaging, if they were not done, they was to be done, and margin negative resection was a prerequisite. Stratification was done among the EGFR mutation. Only two mutations were included, exon 19 and L858R, and race was also one of the stratification factors. Patients were randomized equally into osimertinib versus placebo. It was an adjuvant 3-year duration treatment plan, and the primary endpoint was investigator assessed disease-free survival, and there were few key secondary endpoints as well, which were the overall survival in the overall population, DFS, landmark overall survival,
Some connection is Dr. Stenker, connection is poor on your side. We are not able to listen your voice.
Actually, I'm in Delhi, busy with some family
Okay.
issue.
Okay. No
Next slide,
issue.
Aman. Yeah, so this is the benefit that we derive out of this trial. Look at the delta. The two curves are hugely separating, unlike the Anita trial. In both the subsets, whether you look up to the stage 2 or 3A or the overall population, and look at the hazard ratio 0.23 and 0.27. So these are very rarely seen in any oncology trials. So there was a significantly improved DFS, which was demonstrated in the primary as well as the overall population. Next slide. So there was one more advantage that was seen regarding the CNS DFS. So osimertinib, as we all know, has a slightly more CNS penetration, blood-brain barrier penetration as compared to the other JKIs. So very rarely any CNS event was seen in the osimertinib arm as compared to the placebo arm. So very rare CNS events occurred, and hazard ratio was 0.3 again, 0.23 again, and significantly improved CNS DFS was seen. Next slide, please. So baseline characteristics were very well balanced in both the arms. All the stages were roughly equally 1/3 each, and mostly 96% adenocarcinoma types. Mutation-wise, 55% were exon 19 and 45% were L858R mutations. Adjuvant chemotherapy was given to around 60% of the patients in both the arms. Next slide, please. So coming to overall survival, yes, next slide. Yeah. Now, even if we analyze by the stage wise, so the benefit was far more in the stage 1B as well as the stage 3A. But still, in stage 2, I mean, in all the stages, benefit was seen, but more with stage 1B and stage 3A. Reasons I really don't know. Next slide, please. Now coming to subgroup analysis, overall survival, EGFR mutation, exon 19 benefited more as compared to L858R, and it was the benefit was seen whether you give chemotherapy, H1 chemotherapy or not. But this was not a pre-designed stratification factor. This is a after a study analysis. Next slide. And coming to subsequent treatments, if you see, majority of the patients, almost 54% patients in the placebo arm went on to receive subsequent therapy, including 43% patients actually took osimertinib. So in spite of so much of crossover, the benefit is still maintained in both the DFS as well as OS, which speaks, the benefit actually driven through this drug. Next slide. And safety wise, we all know osimertinib is one of the most safe drug. Although this trial did show that there were around 13% discontinuation rate, but which practically we don't see that happening. And this drug is absolutely safe, and very rarely we come up with found in the Adora trial. Next slide. The Next slide.
So you can make the next slide on the technical team.
Yeah, patient may ask for treatment options for best survival probability, and we need to be ready to discuss and offer them as per the best available data. Adora actually gives us the probability of patients to remain cancer-free, that is disease-free, along with the overall survival benefit also. So being cancer-free is actually the goal which we all aim for. And I think thanks. And that's from my end, and I'm happy to take questions.
Thank you, Dr. Satyankar. So following this trial, we have another trial of this osimertinib, that's LAURA trial.
Yeah.
And again, that in adjuvant setting, post CTRT. So in the latest ASCO, it has shown that patient who received this osimertinib post CTRT, they tend to do better. PFS data is available, which is significantly better as compared to the placebo. But the problem with the adjuvant setting post CTRT is this: we don't have any timeline for the osimertinib. In that trial, that it was taken to be till disease progression. So this is one of the limitation with the LAURA trial in this, which we right now it is one of the talk of the town right nowadays. So that otherwise, so this osimertinib, which was in the second line, the metastatic setting from the AURA trial, then FLAURA trial, the first line setting, then ADAURA as a adjuvant post surgery, post chemotherapy, and now post CTRT, we have this LAURA trial. So thank you, Dr. Satyankar. That's good. So
Thank
Dr.
you so much.
Kunal, do you want to put something from your end? I think sir is not there. So my next speaker is Dr. Suresh. So right now we have discussed one TK in the adjuvant setting, that is the osimertinib. Dr. Suresh will be taking the next of, that is alectinib, and that is in adjuvant setting in patient with the CLL. So Dr. Suresh is a medical oncologist along with me in my same center, that is CCA Amritsar. So over to you, Dr. Suresh.
Yes, sir. Good evening, sir.
Good evening. Good evening.
Kindly share my slide. So I would like to thank the organizers and the attendees for giving me the opportunity to speak on the topic of adjuvant targeted therapy in lung cancer, in as positive lung cancer. Next slide, please. So when we look at the background, we know that the current standard of care after resection of early stage ALK positive NSCLC is adjuvant platinum based therapy. And as we know, there is a modest 5-year overall survival benefit of 5% in the patients with adjuvant chemotherapy. When we look at the 5-year risk of recurrence or death, it ranges from 45% for stage 1B disease to 76% for stage 3 disease. So we know that as the stage advances, the chances of recurrence increases. When we look at the 5-year survival range, it ranges from 71% for stage 1B disease to just 36% for stage 3 disease. So in the further slides, we are going to discuss why it is so much important to look for disease-free survival. As we know, as the disease recurs, the chances of survival decreases for any patients with metastatic lung cancer. As we know, alectinib is a potential oral TKI, TKI with CNS activity. Next slide, please. So we are going to discuss regarding ALINA study, which is a randomized phase 3 trial of adjuvant alectinib versus chemotherapy in patients with stage 1B to stage 3A ALK positive NSCLC. Next slide, please. So when we look at the study design, it was a phase 3 trial in which patients with resected stage 1B to stage 3A ALK positive NSCLC patients were included who were eligible for platinum-based chemotherapy with no history of prior systemic therapy. All patients had a good performance status of ECOG PS 0 to 1. So one arm received alectinib at the dose of 600 mg BD for 2 years, and the other arm received platinum-based chemotherapy, which was every 3 weekly for 4 cycles. So what was the primary endpoint? When we look at the primary endpoint, it was disease-free survival as per the investigator, and the secondary endpoints were CNS disease-free survival and overall survival and safety related to the drug therapy. Next slide, please. So when we look at the stratification, which was as per the age, sex, smoking status, and the racial factors, both the arms were well balanced. And also when we look at the stratification as per the histology, whether it was a squamous histology or non-squamous histology, whether the patient underwent surgical procedures, both the arms were well balanced. Next slide, please. So when we look at the Kaplan-Meier curve of disease-free survival, you can clearly see that the patients who received adjuvant alectinib did better as compared to the patients who received chemotherapy, with a disease-free survival of around 94% at the follow-up of 24 months, that is 2 years, as compared to only 64% in the patients who received adjuvant chemotherapy. On further follow-up at 3 years follow-up, it was found that the disease-free survival was around 88% in the patients who received adjuvant alectinib, whereas it was only 54% in the other arm, with a hazard ratio of 0.24, which was statistically significant. When we come to the right side of the curve, which is the CNS disease-free survival, you can clearly see that the alectinib arm did better with a 2 years disease-free survival of around 98% as compared to only 86% in the chemotherapy arm. And on 3-year follow-up, it was 95% in the alectinib arm, and it was only 80% in the chemotherapy arm. Thus, treatment with adjuvant alectinib resulted in a significant disease-free survival benefit and in a clinically meaningful CNS disease-free survival benefit compared with chemotherapy in patients with resected stage 1B to 3A ALK positive NSCLC. Next slide, please. So when we look at the data as per the stratification factors, you can clearly see that, as I have already mentioned, that the 2-year CNS disease-free survival was 98% in the TKI arm, and it was only 86% in the chemotherapy arm. When we look at the long-term follow-up with 3-year disease-free survival, it was 95% in the adjuvant TKI arm, and it was only 80% in the chemotherapy arm. Also, when we come to the number of recurrences, you can clearly see that the recurrence was very less. You can see that around 115 patients had no recurrence, whereas in the chemotherapy arm, no recurrence was seen only in the 77 patients. When we look at the sites of recurrence, you can clearly see that the incidence of brain metastasis recurrence was higher in the chemotherapy arm as compared to the TKI arm. And in the chemotherapy arm, it was almost 3 times, as compared to only 4 cases reported to be brain metastasis in the alectinib arm. Also, when we look at the other sites of recurrence, they were much lesser in the TKI arm as compared to the chemotherapy arm. Next slide, please. So when we discuss regarding the subsequent therapy post recurrence, you can clearly see that only 15 patients patient had recurrence in the alectinib arm, whereas it was around 49 patients received subsequent therapy, with the most common treatment being chemotherapy in the post TKI progression arm. And in the chemotherapy arm, you can see that patients also received TKI and subsequent lines of chemotherapy. Next slide, please. So now we discuss regarding the adverse events. You can clearly see that the most common adverse events was reported to be elevated CPK levels in the alectinib arm, which was also reported to be, which was the only reported to be grade 3 to 4 events. When we look at the other toxicities, you can clearly see that other toxicities seen in the alectinib arm were in the form of transaminitis, constipation, elevated bilirubin levels, with lesser incidence of toxicities like nausea, vomiting, and anemia to a lesser extent. When we come to the chemotherapy arm, the more common reported toxicities were nausea, vomiting, followed by febrile neutropenia, and also grade 3 to 4 adverse events were reported in all the toxicities. So when we look at the dose reduction, you can clearly see that dose reduction was to be done in around 26% of alectinib patients, whereas it was only 10% in the patients who received chemotherapy. When we come to the adverse events leading to dose interruption, it was reported to be 27% in the TKI arm, and it was 18% in the chemotherapy arm. Also, treatment withdrawal cases were found to be higher in chemotherapy, which was 13%, whereas it was only 5% in the alectinib arm. And the median treatment duration was around 24 months in the alectinib arm, and it was only 2 months in the chemotherapy arm. Next slide, please. So when we discuss regarding the health-related quality of life for adjuvant alectinib versus chemotherapy, next slide, please. So you can look at the chart that the graph that during active treatment with alectinib, the mental component summary and the physical component summary generally improved at the week of 96, and they were similar to the general population. When we come to the chemotherapy, it improved only after the treatment was completed, and similar trends were observed across all the health domains of the patient. Next slide, please. So the summary was that, next slide, please. So the summary was that for patients with resected ALK positive NSCLC, health-related quality of life is an important clinical consideration. And on exploratory analysis of the patient-reported outcome from the ALINA trial, it was found that the alectinib early health-related quality of life improvement from baseline was seen. Improvement in both physical and mental HRQL were maintained over 2 years of treatment, and they reached levels similar to the general population. However, in the chemotherapy arm, patient had no improvement at week 12, and it declined in the general health and vitality domains, and health-related quality of life improved in the post-chemotherapy period. Together with the disease-free survival benefit seen in the ALINA, this HRQL data support adjuvant alectinib as an important new treatment strategy for patients with resected ALK-positive NSCLC. Next slide, please. So what is my take-home message? Would be that adjuvant alectinib showed superior efficacy versus chemotherapy in patients with resected stage 1B, 3A, ALK-positive NSCLC with a disease-free survival benefit with a hazard ratio of 0.24, which was statistically significant. When we come to the CNS disease-free survival, the hazard ratio was found to be 0.22, and adjuvant alectinib was tolerable with no unexpected safety signals. Also, the quality of life was maintained in the patient who received alectinib. Next slide, please. So, what are the answers yet to? What is the future answers which are yet to be answered? Next slide, please. Whether we can go for chemotherapy along with ALK inhibitor or chemotherapy followed by ALK inhibitor in stage 2 to stage 3A disease. What should be the duration of it? Should be whether it should be 2 years duration or more. As we know that deep in disease-free survival after stopping alectinib was seen in the study. We don't have data regarding other potent TKI like lorlatinib, which has a better efficacy but poor tolerance. Definitely in a developing country like India, cost issue is definitely a major issue. At time of data cutoff, overall survival data was immature with 6 deaths, which were around 2.3% reported, 2 in the alectinib arm, and it was 4 in the chemotherapy arm. 76% patient in control arm took post-progression TKI. That is subsequent therapy. Next slide, please. So alectinib is approved by FDA as adjuvant therapy for tumor size of more than or equal to 4 centimeter or node positive, ALK positive NSCLC. Also positive, we have also positive committee for medicinal products for human use for the drug. It is a category 1 NCCN recommendation. Next slide, please. So adjuvant alectinib should be preferred over chemotherapy in ALK positive and lung cancer. Next slide, please. Thank you.
Thank you, Dr. Suresh. So for giving this talk on adjuvant alectinib in a patient with the CA lung in stage 1B onwards till stage 3A. So the other thing which you were just pointing regarding the adverse events that they have increased CPKMB levels. So usually patient who get this 600 milligram BD dosing, in those patients, they tend to have some sort of cardiac problems. And I have encountered in 2 patients that bradycardia. So I just did that dose was made to 450 milligram BD. So that settled the bradycardia and patient was done. So I felt though it is not a very big data, it was from my own experience, but 450 milligram BD is well tolerated dose and there is no compromise in those patients who are even getting 450 milligram BD. Definitely these ALK inhibitors, which was there, like alectinib, which was like a breakthrough patient who had a CNS disease, because CNS penetration of this alectinib is very good. So there is always a point in initial study also, we don't know the timeline for the osimertinib, but for the alectinib, we also there 2 to 3 years. So difficult to define how much time to be given because we are in a constrained settings and we have to define according to the patient's data. So thank you so much. Thank you, Dr. Suresh.
Thank you, sir. Thank you for sharing your experience. Good.
Thank you so much. So my next speaker is Dr. Burhan Wani. He is a senior medical oncologist at AOE Jalandhar. So right now he will be taking for the lecture on atezolizumab in patients with CLR. Over to you, Dr. Burhan.
Good evening, everyone. Thanks, Dr. Jagdeep, for having me today. So At the outset, I would like to thank the organizers for conducting such a wonderful webinar. So my talk will be focused on role of IO, that is the atezolizumab plus chemotherapy plus the VEGF inhibitors in non-squamous metastatic non-small cell lung cancer. So this talk will be primarily on the IMpower 150 trial. So just a minute. So the slides have been provided by the Roche, as it's a Roche sponsored, I think, meet. So now coming to the this IMpower 150 trial. So it was a phase 3 randomized study that was a for the role of first line atezolizumab plus chemotherapy plus plus VEGF inhibitors in non-squamous non-small cell lung cancers. So the key questions that were asked by this trial was whether the addition of IO, that is atezolizumab, plus standard of care, that is the bevacizumab plus the paclitaxel and carboplatin, had added clinical benefit in this patient population. And is there any improved clinical benefit if the bevacizumab arm, bevacizumab is replaced by the atezolizumab? So the study population, if we see the inclusion criteria, what they were there, the patient had a stage 3 non-small cell lung cancer, stage 4 non-small cell lung cancer patients, non-squamous who are chemo-naive, stratified by the gender, PD-L1 expression status, and by the liver metastasis burden. And they were randomized to 1:1 arm in, there were 3 arms that were in the study. The arm A was atezolizumab plus the chemotherapy. The chemotherapy backbone that was selected was the paclitaxel plus carboplatin. The second arm had the atezolizumab plus carboplatin and paclitaxel, along with that the VEGF inhibitor, that is the bevacizumab. And there was a third arm that was the carboplatin plus paclitaxel plus the bevacizumab. And once the patient finished the 6 cycles of chemotherapy, the patient had been provision of giving the maintenance. So it was a non-crossover permitted. So atezolizumab or bevacizumab alone was considered, depending upon what was given in the upfront in the setting. So it was, if we see, it was given until the progressive disease or there was any loss of the clinical benefit. So the primary endpoints of the studies that were there was to assess the PFS and the OS in the intention to treat population. So the basic idea of combining the atezolizumab with bevacizumab was considered because there was what has been found that this, once we are giving bevacizumab along with the atezolizumab, the bevacizumab does lead to enhanced immune related toxicity. So how it does that? It has been seen that once the bevacizumab is given, it normalizes the vasculature, thereby it results in the increased infiltration of the T cells into the tumors. The bevacizumab, it has also been found to result in the reprogramming of the tumor microenvironment. And also the bevacizumab, it has been found to lead to enhanced priming and activation of the T cell responses. And together with, once we are combining the chemotherapy as well, there is more release of the tumor antigens that in turn trigger the immunogenic cell death. So all these features were there, and this was the hypothesis for actually including the bevacizumab with atezolizumab with chemotherapy as far as this study was concerned. So if we see the baseline characteristics, they were well balanced between the various arms. So overall, if we see here in this baseline characteristics, we can see patients with liver metastasis were enrolled, and close to around 14% of the patient, they had liver metastasis at the baseline, which was stratified in the IMpower 105 trial. Then also the study had enrolled the patients who had EGFR mutations, and almost 10% of the patients had EGFR mutations, and they were also balanced across the various arms. Besides that, the study also enrolled the patients as far as the PD-L1 status was concerned. So there were patients enrolled where the PD-L1 positive as well as the PD-L1 negative patients were enrolled. So almost 50 to 50 was a ratio as far as the various arms for the PD-L1 status was concerned. So now if we see the initial overall survival that was reported by this study, so there was a significant OS benefit that was seen with the addition of atezolizumab as far as the arm B, where the atezolizumab with bevacizumab plus chemotherapy versus chemo plus anti-VEGF therapy was there. And it was found that there was close to around 4.5 months of difference as far as the OS was between the two arms. And we can see here the hazard ratio of 0.80. And at 24 months, 43% of the patients they were alive versus 34% for the VEGF, anti-VEGF plus chemotherapy alone arm. So another thing that was there was, as far as the overall responses and the duration of the response was concerned, here also it was found that patients who were given the 4-drug combination, we can see here that the 56% of the patients, they achieved objective response rates, and versus 41% for the chemo plus anti-VEGF therapy arm. And if we see the median duration of the responses, it was 11.5 months for the 4-drug regimen versus 6.0 for the
Bronze connection is lost. So, Abhimanyu, can you check with Dr. Buran once? Abhimanyu? टेक्निकल टीम
सर मे बी सर से नेटवर्क इशू ना, मैं कॉल करता हूँ सर को।
just give a call once.
Yeah, sorry for the
no
technical
issues.
glitch that was over there. Am I audible?
Yes, Dr. Buran, you are.
Yeah. So that was about, as I mentioned, that the oral responses and the duration of responses, it was significantly better for the 4-drug combination versus the chemotherapy plus anti-VEGF therapy arm. Then again, another thing that was highlighted by the study was that the OS benefit, it was observed across the various PD-L1 subgroups. As far as the intention to treat population, we can see here that even patients who had PD-L1 low or zero, they had a benefit versus the patients who had PD-L1 high. But definitely PD-L1 high patients, they derived the most of the benefit with this arm. So we can see here that for the PD-L1 positive, where it was low or high or zero, there was a benefit as far as the responses were, overall survival benefit was concerned. Definitely the survival benefit was relatively less in patients who had PD-L1 zero than patients who had PD-L1 positive patient population. Now, another thing that was seen in the study was for the various subgroups. The first subgroup was there for the EGFR mutation positive after the patient had failed the EGFR TKIs. So we can see in the study, almost 160 patients, they had been enrolled for the various mutations that were seen. And for EGFR mutations, there were 124 patients. With the EGFR sensitizing mutations, they were in 91%. And the sensitizing mutation that had received the prior TKI therapy, they were around 78. So here again, there was a clinically meaningful PFS benefit that was observed between the 4-drug arm versus the 3-drug arm in patients with EGFR mutation positive and ALK positive non-small cell lung cancer patients. So this is one of the things that we have from the study that we can use following the patient. Once the patients have failed the anti-EGFR therapy, these patients can be taken for the combination of IO with anti-VEGF and chemotherapy, and there was a significant benefit as far as the PFS was reported, with a hazard ratio of 0.59 in the study. So same was seen as far as the overall survival. Again, it was seen significantly better for the two arms. Now, this is about the same about the whether what was the OS once the patient has sensitizing mutation with the prior TKI therapy and they were given the treatments. So overall, another thing that was there was the overall response rate and the duration response, and it was also remarkable as far as the 4-drug combination was there. It was 71% for the 4-drug regimen versus the 42% for the 3-drug arm. And if we can see here, the duration of responses, again, they were significantly better for the 4-drug combination arm. Now, another key subgroup that was highlighted by the study was for the patients who having the liver metastasis. Here also, the 4-drug arm of atezolizumab plus bevacizumab with chemotherapy, it showed there was a clinically meaningful PFS benefit in patients who had liver metastasis at the baseline. And there was a close to median PFS was the difference that was reported. It was 8.2 months versus 5.4 months for the 3-drug arm. And we can see here that at 18 months in the arm, that was the 4-drug, that the ABCP arm, it was 23.3% of the patient, they were progression free versus 1.8% for the BCP arm. So again, there was a same was translated in the OS as well. There was a OS benefit that was observed in patients who had liver metastasis when bevacizumab was added to the atezolizumab arm. So this is the same thing that once we had given the bevacizumab with the atezolizumab, there was a benefit in the OS as well that was reported by the study. So same was another thing that was seen was the overall response and the duration of response. Here also, the overall responses was 60.8 months, 60.8% for the ABCP arm versus 41.1% for the BCP arm. And the median duration of response was 10.7 months for ABCP arm versus 4.6 months for BCP arm. So so overall, it nearly doubled the duration of response with the addition of bevacizumab plus atezolizumab and chemotherapy in patients with liver metastasis. So another thing that was observed in the study was patients having the bulky disease. So bulky disease, it was chosen based on 2 parameters. That was the dimensions and the number of metastasis sites that was there, and it was stratified by the low burden versus the high burden arm, high burden disease. And here also it was seen that patients who had high burden of disease, they derived better benefit as far as the ABCP arm was concerned. So this is the slide that was showing that there was the median OS, if we can see for the ABCP arm for the high burden disease, it was 15.5 months versus 10.7 months for the BCP arm. And same was for the overall responses rate also. It was 62% versus 41% for the BCP arm. So overall, if we see this 4-drug regimen of ABCP arm, it was well tolerated, but definitely we know that once we are adding more and more drugs, we will be getting some sort of toxicities. There were toxicities, but majority of them, they were manageable toxicities, and overall no safety signals they were identified. The profile that was there, that there was associated, there were some higher degree reports of grade 3 to 5 adverse effects that was reported, but majority of the patients they were manageable. So if to summarize the IMPower 150 trial, it met both its co-primary endpoints, and it was the first and only phase 3 trial where chemo plus immunotherapy plus anti-VEGF therapy, that is the ABCP arm, it demonstrated a statistically significant and clinically meaningful improvement in PFS, OS in all comers, first-line non-squamous metastatic non-small cell lung cancer patients. So it gives us a provision of using this sort of a combination where we where the patient, if the PD-L1 status is unknown, or patients where the patients have progressed after the patient progressed to anti-EGFR therapy, or who have received the ALK therapy, and then they have progressed, and also the patients who have the liver metastasis. And clinical benefit from the addition of atezolizumab with bevacizumab chemotherapy, it was observed with or without bulky disease, further supporting its use as a first-line option for patients with high burden disease. And atezolizumab in combination with chemotherapy and bevacizumab, it appears to be well tolerated, and its safety profile is consistent with the previously known safety risks. So with this, I would like to thank my talk. Thank you for having me.
Thank you, Dr. Buran. So it was insight into this combination of this IO plus anti-VEGF with the backbone of the chemotherapy. And definitely it showed a benefit in patient with the metastatic CL lung. So the thing is that initially when I used to analyze this atezolizumab plus bevacizumab combination in comparison with the pembrolizumab, as a finance, I would like to think that it is bit cheaper. But right now, when we have a good PAP with the Keytruda, so then I'm a bit reluctant to use this combination as comparison to Keytruda. And though, of course, this is not a dependent on PD-L1, that initially you can start and then you can subgroup analysis showed that with the higher percentage of this PD-L1, you can get a better result. But initially I used to focus because we don't have any head-to-head trial which drug is better. Both are category 1 recommendations for a patient with a CL lung. But now I sometimes think whether I can use a combination of this 4-drug and followed by maintenance with a dual combination.
So overall, what I have seen that the little bit toxicities of the this sort of regimen is over there. So that I have given in 2 patients, and somehow I had to actually decrease the dose of the chemotherapy. That's what I have experienced. But overall, it can be considered, as you mentioned, that it can be considered in some of the patient populations that we can do.
Thank you so much, Dr. Baran. So for giving a talk on atezolizumab plus bevacizumab in the CL lung. So next talk is by Dr. Kunal, and it will be our how we'll deal in real life practice patient with the stage 3 lung cancer. So Dr. Kunal does not need any introduction. So my senior and of course my guide also. Thank you, sir. Thank you. Always be there. You're always there when I need you. Thank you for your support to me.
Thank you, Ji. Thank you so much, Dr. Jagdeep, for your kind words. I hope the slides are there.
Yes, sir. So they are in the presentation. Yes.
Okay, good. Okay, so we are on time, which is a good thing. So I think it is my duty also not to delay the dinner for all those who will pending. So it's basically a very focused discussion about patients with stage 3 non-small cell lung cancer. What do we do in real life? And this is one of the cases which has been treated by someone else and has been the slide set has been compiled and sent to me. But this is something that we would also be seeing in our practices. Not so common, I must say. Stage 3 or curable uh, lung cancer patients are not very common in our practice. They are kind of scarce. So this is a 52-year-old male who we can consider is a smoker and had presented with weight loss, dry cough, no other comorbidities. And his initial X-ray showed an opacity in the left upper and mid zone with some perilesional haziness and bilateral apical thickening, which was reported on the X-ray. A subsequent CT showed a large mass in the apicoposterior segment of left upper lobe and also few subcentimeter and few enlarged mediastinal nodes, which were suspected to be involved by cancer. And his PET scan, which was done, showed FDG-avid or metabolically active lesion, which was more than 8 centimeter in left upper lobe, and it was abutting the both costal as well as mediastinal pleura, making it a T4 lesion, and it was also abutting arch of aorta and encasing left upper lobe bronchus. It also showed mediastinal nodes on the contralateral side of mediastinum, which are not very well shown or depicted on the PET images here. And it made it N3 disease, finally clinically staging it to be T4N3, which will fall into T3C. There were no distant metastases, and I assume this patient will also warrant a MRI brain after histological confirmation just to rule out brain metastasis, so which we can take that it was negative. A biopsy from the lung lesion showed it to be a poorly differentiated adenocarcinoma supported by IHC. And for the sake of discussion, let us take that this patient did not have any biomarker positive test, which I think for two, at least EGFR and ALK, maybe for curative setting we can take. So when we talk about stage 3 tumors, so it is again in itself a heterogeneous group, including 3A, B, and C. I'll not go into details about what entails into each one of them because all of us know about the AJCC 8 staging and the changes as from the previous staging in terms of tumor size also and also the multiple nodules which are seen in the same lobe or in the same side of the lung. So why is staging important? We all know that as the stage increases, the outcome in majority of the cancers become poorer, and that is similar in lung cancer as well. You can hardly see any 5-year survivors from the previous 5 stage 4, but now I think in biomarker driven stage 4 cancers, it will not be surprising to see patients who will be surviving 5 years or longer. But focusing on stage 3, which again is a dismal outcome, patients who are even pathologically staged as stage 3 A to C, the outcomes 5-year survivals are less than 50%, and even in 3C it's about 12%, which is quite dismal. So in terms of staging, so that was a clinical staging for 3C. We had a previous presentation on EBUS, and it was very nicely presented how to evaluate patients. So go from higher to lower station. So you would evaluate a N3 node first, and if it is positive, obviously it will give you that kind of staging. So you can do it by a non-invasive methodology by your imaging, which is CT, MR, brain, and also a PET. PET has a good role in lung cancer staging. or by invasive staging methodology, which will include EUS or EBUS as a non-surgical modality, and patients may need mediastinoscopy or a VATS procedure by trained cardiothoracic surgeons or the people who are trained in that modality. And PET has a sensitivity of 80 and specificity of 88%, as opposed to a lower sensitivity and specificity that is seen by CT scan. And in our setup, we always have to be cautious about coexisting tuberculosis. And again, in that EBUS presentation, it was so nicely pointed out about granulomatous findings which can come up on your EBUS and cytology or biopsy. So again, this slide is showing accuracy comparison of staging tests, which could be mediastinoscopy, EUS, EBUS, or a combination of either EBUS or EUS. And you can see once these tests are done, and if they are negative, their specificity is almost 100%, that patients will be unlikely to be having disease at that nodal station. And these are fairly large numbers for lung cancer, if you can see in some of the studies. So a brief overview of current treatment. Stage 1, patients are candidates for surgery, or occasionally now SBRT if the patient is very elderly or unfit for surgery. And stage 2 patients obviously will be for surgery and for adjuvant therapy, depending on what is the histology. And also there is some role of adjuvant immuno in addition to chemotherapy. For stage 3 patients, again, the standard of care is concurrent chemoradiation, followed by consolidation immunotherapy, and that is what we will be seeing in subsequent studies as to the Pacific trial data, and also in select subsets where you find EGFR, especially the EGFR mutation based on the LAURA study, you can consider them for adjuvant osimertinib. So, and stage 4 patients, we know depending on their biomarker, we can consider them for targeted therapy, or majority of those patients will be for chemo plus minus immuno, depending on their affordability. So in cases which are unresectable stage 3, we have to have loco-regional control. Also consider systemic control, because there will be obviously micrometastatic disease, and most of the patients will have will die of metastatic disease and from distant metastasis. And brain is also one of the sites for metastasis. So coming back to our patient, which had stage 3C adenocarcinoma lung. So question again is, what would be the ideal modality for this patient? I think if we go by the data, this patient will qualify for concurrent chemoradiation, but some of us will also consider induction chemotherapy, although this is not a standard protocol, but giving chemo first and till maybe especially at high volume centers where radiation treatments are getting delayed. This may be one of the approach to follow, to give induction chemo. And the choice of chemotherapy in adenocarcinoma can differ. You can use you have to use a platinum, and in terms of what you use companion to platinum is your choice. There are all molecules are kind of used, and in adenocarcinoma, pemetrexed also has its role. So this patient got paclitaxel day 1, 8, and 15, and carboplatin. You can also use cisplatin if patient is fit, and this is a young patient. And due to hypersensitivity to paclitaxel, he got nab-paclitaxel subsequently, and post 3 cycles, PET did show partial response. So I mentioned that we use this kind of strategy sometimes for our patients, especially if they have bulky disease. And even in the landmark Pacific trial, there were about 1/4 of patients who had received induction chemotherapy preceding definitive chemoradiotherapy. So after induction chemotherapy, once the PET showed that patient had good partial response, this patient was planned for chemoradiotherapy with again weekly paclitaxel carboplatin with radiation. And radiation dose was 66 gray in 33 fractions, and he tolerated treatment well. So what do you use in terms of companion chemotherapy? Again, is there are wide options, but I think majority of us now have use paclitaxel carboplatin because it is quite patient friendly and least toxic. But previous studies had used etoposide cisplatin especially, and there were other Vinca alkaloids also which were used in combination with platinum. So there is always a question whether we give sequential or concurrent chemoradiation. Sequential means one modality at one time, radiation first and then follow it up with chemotherapy, or we'd give both together. So I think this question has been put to rest that definitive CTRT is the standard of care. There is an incremental benefit of about 5% or so in terms of survival at 5 years if the patients are given chemoradiotherapy, and not only in the controlled trial setting. This has also been shown in the real world setting data with this study which was presented at ASCO 2020, close to 3,000 patients, where they had seen what were the outcomes with different types of modalities of treatment for patients. And patients who got combination chemoradiotherapy or concurrent chemoradiotherapy, their outcomes were best as opposed to other modalities. Obviously, patients who are candidates for surgery usually will be earlier stage. Their outcomes were the best out of all modalities, but among radiation, sequential chemoradiotherapy, chemotherapy alone, or concurrent chemoradiotherapy scores over all modalities in terms of outcome and response. So once we have given them chemoradiotherapy, what do we do next? Because majority of these patients again will have relapse, and their progression-free survival is usually about 6 to 7 months. So can we do anything in terms of improving the outcome? Various studies, the most famous being the SWOG with the consolidation docetaxel also was done, but they failed to show any improvement over the conventional CTRT. So this patient developed radiation pneumonitis because I think you can see the initial volume of the tumor was also quite large, and post development of this complication, patient was started on steroids, and gradually in 3 to 4 weeks he had resolving symptoms and had tapering of dose of steroids. So then again the question comes whether this patient can be considered for immunotherapy or not. Based on the data from Pacific trial, which was a phase 3 randomized double-blind multi-center international study, and included patients with stage 3 disease who had received 2 or more cycles of definitive platinum-based concurrent chemoradiotherapy. Again, here it's mentioned 2 or more cycles. If you see the actual trial appendix or supplementary appendix, there were about 12 to 15 chemotherapy regimes, including both carboplatin and cisplatin and various combinations of other drugs, and very small percentage getting only a platinum, which were used in these patients. So at least 2 cycles had to be given, and archived tissue was also collected. Patients were randomized 2:1 to durvalumab 10 milligram per kg IV every 2 weeks for 1 year, or to placebo. And this randomization was done between 1 to 42 days post concurrent chemoradiotherapy. So co-primary endpoints were PFS and as well as OS, which is important. Ultimately, we want to see whether with this study, with this treatment, patients are living longer or not. And initially, I mentioned all patients received 2 or more overlapping cycles. And previously, also in one of the slides, I had shown that about 27% patients received induction chemotherapy prior to study start. So induction chemo followed by concurrent chemoradiotherapy, and then they would, depending on the response, obviously patients who had partial response, stable disease, or complete response would be enrolled for further treatment with the immunotherapy. And what it showed that in terms of overall survival, there was significant improvement in terms of overall survival by in patients who got durvalumab. And at 5-year mark, this difference was close to 9%, 43% in durvalumab arm as compared to 33% in the placebo arm. And in terms of median overall survival number, it was again close to 1.5 times, or almost nearing more than 1.5 times, 47 months versus 29 months. So important numbers to remember, that at 5 years, 43% of patients will be alive. In terms of progression-free survival, again, it was almost 3 times as compared to placebo, 16.9 months as opposed to 5.6 months. So majority of patients who were on placebo post ETRT were progressing within the initial 6 months. More than 50% would progress. And patients had fair representation, majority just marginal increase in non-squamous as opposed to squamous. And they also tested PDL1. Again, it was tested by SP263. And they had kept this cutoff of 25% versus more than 25% versus less than 25%. And majority of the patients in this study had, as per this cutoff, lower PDL1. And EGFR positive patients were about 6%. And what this forest plot is showing, that irrespective of the subgroup, durvalumab kind of favored all, except maybe EGFR positive, where the benefit was less. But again, we have to be very mindful that the numbers of those patients were very, very small. And the updated OS and PFS, which was presented at ESMO Lung, again showed that irrespective of the various factors, the improvement in OS and PFS was seen irrespective of the subgroup with durvalumab. So when do we assess patients for response and for considering durvalumab? Obviously, patients who can afford this modality. PET may not be the best kind of modality before 12 weeks, sorry. But if we have to just get a bigger picture, a rough idea, PET can be done, or otherwise a CT can tell us, especially what kind of response is there, or especially there is no progression. So this patient did get durvalumab, but it was much later than what was the initial planned as per the trial. And again, these pictures are trying to show that there was significant reduction in the mass as well as in the metabolic activity of that lesion. So other than the trial, is there any real world data? So this French data analyzed about close to 600 patients with stage 3 cancer who had again similar kind of setting. They had received chemoradiotherapy with the same doses, 54 to 66 gray, and they were considered for durvalumab. And there were both subsets. So this small percentage of patients did get durvalumab more than 42 days, which is about 7 weeks from completion of chemoradiotherapy. And this trial showed that even in those patients who got delayed durvalumab, there was a similar kind of benefit that was seen with the Pacific study. So this patient continued on durvalumab and showed benefit as was expected from durvalumab. So this trial has established durvalumab or Imfinzi as the standard of care for patients with stage 3 lung cancer post CTRT. Again, the proportion of the patients who get this modality of treatment is very small. So from the traditional overall survival of about 15 to 25%, we are looking at a survival, 5-year survival of about 43%. And if we see various guidelines, including the Indian expert consensus guidelines NCCN as well as ESMO, durvalumab is mentioned as one of the modality. Only ESMO mentions it based on PDL1 more than 1%. So concurrent chemoradiotherapy gives better outcomes than either therapy alone or in sequence. And consolidation chemotherapy usually does not improve outcome. No study has shown that it has improved survival. So immunotherapy, among immunotherapy, durvalumab remains the only therapy which has shown to improve both PFS as well as, more importantly, OS at all the time points, and we are looking at 43% survival at 5-year mark. So, and it is also showing out improvement across all subgroups irrespective of PDL1 status. So this establishes this drug as one of the standard of care in stage 3 unresectable non-small cell lung cancer. So with that, I will end, and if there are any questions.
Thank you, sir. So one thing is clear, sir. First, stage 3C, that is N nodal status N. So CTRT followed by durvalumab, or in patient who are they are EGFR positive, which that LAURA trial has shown, can be one groups which do not do well with the durvalumab. So can be the osimertinib can be the choice on those patients.
Yeah, we recently had a patient
Because
also.
we have a new adjuvant settings. Now we have adjuvant immunotherapy, adjuvant TKIs. So this is one group with N3. Still this durvalumab hold goods other than who are EGFR positive. So
I think the dosing is also more convenient now. There is an option of using 4-weekly durvalumab also in this setting, so which makes it even more convenient.
Yes. Thank you, sir. Thank you so much. So thank you, Dr. Devinder. So disturbing your vacations. Sorry to bother you, but so it was on like we don't want to disturb your vacation, but one of the lecture was there from your side. That's why I kept at the time that you can give us some time. So next lecture is from Dr. Devinder Pal, my colleague at DMC Ludhiana. Now he's heading medical oncology at Fortis Ludhiana. So Abhimanyu, can you put the slides for Dr. Devinder?